this amazing webinar that today we have here. Where are you guys from? We want to know where are you guys watching this, where are you guys from, and tell us where are you right now. So we want to invite you to be part of the OU ecosystem. We're in all the social media platforms. You know, I love YouTube channel because we have more than 5,000 subscribers. All the videos of Ophthalmo University are there, so you can go there and watch it, all of them. Even this video, it's now on live in YouTube, and if you cannot stay with us all the webinar, just when we finish this webinar, we upload the video in the YouTube channel. Also, I want to invite you to check the new website of Ophthalmo University. It's totally new. You're gonna find a lot of interesting things, so check it out because it's very, very good, the new website that we have. Another invitation, Ivo, you're here. Would you like to talk about the Stop and Nothing and this webisode that we have every Wednesday? It's incredible.
Yes, thank you, Andres. Welcome, everybody. And this is some webisodes, okay? There are episodes, but in the web, and the key here is the environment. We're doing, we are inviting a couple of experts, but we are talking about cataract surgery, in this case, surrounded with cameras, 5 cameras actually, and all we need to do cataract surgery. So, you know, we're talking to experts, we're demonstrating, doing a couple of surgical techniques, and you know, it's amazing. So we invite everybody next Wednesday to be with us.
Thank you, Ivo. Okay, I want to stop sharing because I want to, exactly. We are all here. We are very happy. It's an honor to have these amazing speakers. We're going to talk about a hot topic today, we can say, right? I want to introduce Valeria Sanchez and Ana Mercedes Garcia. They are the organizers. Thank you so much, guys. And this is your time. Welcome.
Thank you, Andres. Well, I just want to thank you all for joining us, all the professors at this meeting, Susan, Dr. Melchor Sanchez from UNAM, Jorge Valdez, and Gabi, of course. And all of you who are watching from your houses or from wherever you're joining us, thank you. This is a webinar about challenges, the challenge we are facing through this COVID era, as the title says, with specifically with our residents and all the students. This is not going to be over soon, and it is important to know how to manage the practice in ophthalmology and how different parts of Latin America and the United States are going to be dealing with this. Ana Mercedes, can you please help me introducing our guests? And thank you all.
Sure, thanks, Valeria. I want to say something in Spanish para los que nos están oyendo, que sepan que vamos a tener traducción en vivo del inglés al español por nuestros invitados. So we will have the translation all the time. And we will speak in English because we have some guests that does not speak Spanish. So everything that you want to ask or something, Jorge Hernandez from Guatemala will be helping us. So I want to thank him for the translation. And first of all, as Valeria said, I want to thank everyone for being here and to the speakers for accepting our invitation. So we decided to organize this webinar because we have faced these situations with the residents during the COVID-19 pandemic. And personally, I want to know the problems that everyone is having because I know that it will be different for every people or every person in the room or in the webinar. I'm not sure if you are able to see my screen.
Perfect.
Yes.
So we invited 5 important speakers that will be talking with us about the problems that they have faced during this pandemic and the challenges that are coming in the future and what they do or what would we do and how we can change all these problems. So I want to thank all of you for being here and to thank you for exchanging your experiences, your perspectives, for talking about your challenges. And this way we can spread the information and the solutions for the medical education in our near future. Our speakers, first of all, I want to thank Dr. Gabriela Palis for being here. She's a recognized in Argentina, Buenos Aires. She's also the residency program director and the director of education of the same hospital. She's actively involved in the International Council of Ophthalmology as a member of its advisory and strategic committees. She's the chair of the Eco-Teaching Teachers Committee, and she's editor-in-chief for the Center of Ophthalmic Educators. So thank you, Gabriela Palis, for being here with us. Our next speaker is Dr. Susan Pershing. Dr. Pershing is an ophthalmology faculty of Stanford University School of Medicine. She has an academic career blending with clinical practice, teaching, research, and administration. She also serves as the program director for Stanford University Medical Center Ophthalmology Residency, and she's the chief of ophthalmology for the VA Palo Alto Healthcare System. So also thank you, Dr. Pershing, for being here with us. Our next speaker is Dr. Chris Alaviar. I'm not sure if I pronounced your last name fine. He's a distinguished oculoplastic surgeon at Bascom Palmer Eye Institute, and he's also an associate professor of clinical ophthalmology at the same institute. He's the assistant dean for students affairs in University of Miami Miller School of Medicine, and he will be taking over as the residency program director in January next year. He has been very active in the administration of the Bascom Palmer residency program during all this COVID pandemic. So thank you, Dr. Chris, for being today with us. Our next speaker, Dr. Jorge Valdez. He's a prestigious corneal specialist here in Mexico. Currently, he's an associate professor of ophthalmology at Tecnológico de Monterrey, and he is the dean and head of faculty of the School of Medicine of Tecnológico de Monterrey. He has been in different educational positions for the last years, and currently he's the president of the Pan American Foundation of Ophthalmology and the president of MARVO. And last but not least, Dr. Melchor Sanchez, who is a Mexican pediatrician and medical educator. He has the degree of Master's in Health Professional Education and PhD in Educational Science at UNAM. He's also a professor at the Postgraduate Studies Division at the UNAM too, and he's responsible for the Master's and Doctorate in Education in Health Sciences in the same university. He's associate editor of journal Advances in Health Sciences Education and the editor of the journal Research in Medical Education at UNAM. And he has recently been appointed director of the Coordination of Open University Educate Innovation and Distance Education of Universidad Autónoma de México. And finally, our popular hosts and moderators, Andres Benatti and Ivo Ferreira. I want to thank them for letting us be here. So let's start. I don't know if Andres or Ivo want to start with the questions for our speakers.
No, it's fine, Anna. We can start with the first question. Do you have it? Perfect.
I have it there.
So our first question is, which one will you consider is the biggest problem in your institution during COVID-19? If you agree, we can start with Susan. What do you think, Susan, about?
I think the two key priorities that we face are ensuring high quality patient care with safety for our staff and patients, while also coupling with education, which is a key focus of the webinar. But our biggest problem, our chief priority, is being able to provide care safely to our eye care patients and ensuring that no one loses vision or is irreversibly harmed by lack of access to care during this pandemic, while also making sure that they're able to come in and receive their care safely. So we've had to institute a number of changes in our clinic hours, our workflow, to screen patients before they are seen, to ensure that they minimize their time within the clinic and contact with others within the clinic, and to make sure that our staff and providers are screened for potential COVID exposure or COVID symptoms, and also provided with adequate personal protective equipment, wearing masks, wearing gloves, hand washing, and distancing to keep everyone as safe as possible. We also, of course, want to ensure that our trainees receive education and maximize their time and experience while shifting as much as possible to virtual sessions like this one for things that do not need to be done in person, or encounters with patients that can also be done virtually.
Awesome, awesome. On the other part of the world, we have Gabriela Palis in Argentina. Gabriela, what can you say about this question?
Sorry, I was silenced. The main challenge that we faced was due to the strict lockdown that the government forced in March in Argentina. So all our consultations were canceled and were transformed into teleconsultations. In fact, we had to organize a teletriage service. So all patients had to go first to the teletriage service, and those who strictly required attention were the ones that went to the hospital. And this implied the cancellation of all the residents' rotations and surgeries. Residents were grouped into epidemiological groups. This meant that they had to go to the hospital 1 week and they stayed at home for 2 weeks. And on the week that they had to go there, it was for seeing patients with an emergency or those that were referred by the teletriage service. Also, surgical training, as I said, was severely reduced. This lasted for 2 months, and after that, it very, very slowly opened. But with the increase of patients had been very slow. And in fact, subspecialty consultations have started again this month. So it's been 6 months almost that residents had no rotations or very little surgery.
Wow, that's a lot of time for the residents and fellows, right? We will be speaking about that in a few minutes. Chris, what is your opinion about this in Miami, on the other side of the country, in America, in US?
Yeah, thanks, Andres. You know, we actually have a 24-hour emergency room just for ophthalmology. So the Bascom Palmer Eye Institute emergency room is open for anyone at any time. And our biggest challenge was very similar to Gabriela and Suzanne's, and that was to ensure that we were able to continue to deliver care to those who were in need, especially those who had limited access as a result of the lockdown, where people really weren't able to leave their homes unless they were going shopping for food, et cetera. And the challenges we faced with that included the availability of PPE. There was no PPE available in large enough quantities to ensure that every single person had PPE at every time. So we had to have some logistical work to ensure that those who were seeing patients were adequately protected. We wanted to make sure that we maintained a healthy workforce, because in order to keep the emergency room open, we needed to make sure our residents were healthy at all times. And so we put some restrictions on who they would be seeing and how they would be seeing it. The patients would be very carefully screened upon entering the Bascom Palmer Eye Institute, when coming into the emergency room, and the urgent clinics that we kept open for some very select patients who were in need. We also had to make sure that the residents were safe as they would do consultations at our hospitals. We have 3 hospitals that our residents rotate at, and we wanted to make sure that the residents would continue to be able to function safely. So we restricted the residents from seeing any patients who were tested positive from COVID-19. And those patients would be seen only by faculty members, so that we can ensure that the faculty members would be the ones at the front lines rather than our residents, who are really the force in our emergency room. So our keys were to really keep things as safe as possible for everyone. We also had to develop a positive pressure room in the first floor of Bascom Palmer for any patients who came in with conjunctivitis, because we were worried about those potential undiagnosed COVID-19 patients that may have come in with conjunctivitis. At that point, it was really unclear the relation of conjunctivitis and COVID-19, so we wanted to be extraordinarily careful. We also had to create positive pressure rooms in our in our operating room for cases that required urgent care for ophthalmic surgical emergencies that needed to be addressed and could not be ignored. So there were a number of challenges, and I think as we continue with the webinar, we'll recognize that those challenges evolved as the pandemic evolved, as our comfort level with COVID-19 evolved, to the point where now things are quite different than they were when we all started this in late March.
Sorry, absolutely. Any comments from the rest of the panelists, Valeria, Ana, before we continue with Melchor and Jorge? Okay.
No.
Dr. Sanchez, sí, Valeria, you want to say something?
No, go ahead.
Okay, Dr. Sanchez, what is the situation about this in the UNAM, one of the most bigger university in the world, right?
Yes, well, thanks for the invitation. I have just one question before I start speaking. I see that you are recording this. I assume this will be available for the whole world later, because as you know, in Mexico, we live in this situation where science is being discriminated and harassed by the government. So we are living a very difficult situation. And when we complain about things, for example, the answer to this question, the biggest problem, there are so many problems. And the thing is that the Mexican residency education system is so different from the UK and from Canada and from the United States that I think that the biggest problem is a pre-existing condition, the pre-existing condition of the education and residency system. Because in countries like ours, it varies a lot between private and public institutions, but in Mexico, at least, the integration, the appropriate integration educationally and logistically of the residency training programs is, how can I say this euphemistically, of not very good quality, you see, because I think that this previous pre-existing condition in the residency education system in Mexico, what the COVID pandemic did was expose the whole ugly things. It's like when you lift a stone and there are a lot of worms beneath. There's the complete lack of planning. I know that nobody could plan for what we're living now with the COVID pandemic, but it was apparent that there was a complete lack of planning of the healthcare system, and that's probably the biggest issue during the COVID pandemic and onwards. I mean, the lack of an appropriate integration between the healthcare system, which is of very low quality overall, and the universities. This not very good communication and coordination with all the different universities and hospitals, which the net result was that the residents, which usually in Mexico are overworked guys, and they carry a lot of the clinical care in public hospitals, suddenly they continue being in the hospitals with very little support for several reasons. And in the first month, there was this huge issue of the lack of equipment. The protective equipment in many hospitals in Mexico was, to say the truth, very, it was like a horror movie for the residents. So I think the difficulties of the healthcare system and the lack of support from the government to really work as a team to confront the huge problem that we have contributed to this initial chaos. And individual teachers and individual programs and hospitals started responding, doing what they could with their own resources. And fortunately, physicians, we are a very passionate breed and we like to do things, and teaching is very important. But at the end of the day, you need the resources and you need the support of the whole system. And just to point something, there was this, they call it COVID-pedagophobia, this phobia to the online teaching, because most people are used to teaching face-to-face, and suddenly you have to teach online. And if you are not familiar with the online environments, you make a very lousy job as a teacher. So this emergency remote teaching and the lack of faculty development for the majority of teachers in the medical residency systems. I mean, everybody was working and doing the best they could, but the formal curriculum, the scheduled surgeries and the skills and competencies that were supposed to be acquired in that period of time were completely derailed. So, I assume we will talk a little bit about that in the next segments, but it's a systems issue at the end of the day. That would be my comment.
Thank you, Melchor. Very interesting. I think we are all with the same problem in Latin America. We don't have a plan for this pandemic, right? Nobody, but our situation is totally worse. Dr. Valdez, your opinion, please. What do you think?
Andres, well, thank you for the opportunity, for the invitation to be here. Let me talk. I think it's not prerogative of Latin America. I haven't found too many good examples of good dealing with the pandemic. Europe is not doing well. Our neighbors in North America are not doing that well. We are not an example, Latin America neither. So there are a few good examples on how to deal with the pandemic. That in general sense, I'm talking. But one of the main challenges is that we have to develop new skills. And a lot of times it has to be transformative skills. Really, we need to reset our mindset in order to change. And I think Melchor pointed out several things very important. Our faculty in general, the faculty of the School of Medicine, and I have a lot of contact with other faculties, is a very conservative one. They don't like to change. They like to do the things they used to do. And they usually operate in this paradigm and says that, well, I'm very good. So if I'm very good, I was trained that way. Let's keep it doing that way because it's a. So we have we were forced to change the way we teach, and I'm talking particularly in clinical settings. So a lot of people says that is not possible. It has to be that way or not. So and thanks God, a lot of the new teachers, people who more open mind, start to do very interesting things. Online teaching, what we call on place, what like increased reality, rounds with taking the tablet with them and seeing one is seeing the patient, but others outside the room are seeing. So this really gave us the opportunity, to increase the innovation in clinical teaching. And the other things that we have to deal with, there's a challenge. We have to deal with the anxiety of the faculty and the residents, because if you think the faculty is conservative in the way they think, the residents are worse. They think they have to do the things the same they were doing in the previous way. Took us a lot of time to change the mind of the residents, and we face a very big challenge here because we have to transform one entire hospital to COVID entirely. One of the two big hospitals that we have in center. And because the amount of people in probably the largest COVID hospital in Mexico, even the public ones, even the ophthalmology residents have to learn some new skills to deal with patients with COVID and support the rest of the teams. That really creates a problem for the residents. I have some resistance, and they still, for some of them, they are how to say, dealing with learning that there's a learning opportunity over there. Then they can develop new skills. They are extremely focused on technical skills, mainly related to the surgical training. So there are a lot of new skills that they may develop, and there's a wonderful learning opportunity having a pandemic. At least is my second one. So for new ways of thinking, learn about systemic thinking, the new types of organizations, adaptability. A lot of, I can spend the rest of the afternoon just talking about the new learning opportunity that this pandemic provides to us. The other main challenge for the residents, and this is what's having conversation with them, talking with them, is the loss of freedom. This generation, and I think this is something wonderful, values a lot of the freedom of doing what they decide to do. Let me give an example. So they have a lot of, they struggle when they are not doing what they plan to do. They plan what they are going to see in the TV or the computer, what music they want to hear. Everything is chosen by them. Melchor and myself, who are the older ones in this group, when we were kids, we don't decide what we see in the TV. There's open TV, you have to see what appears over there. So I didn't realize that until I started to talk with them. So that's why for the residents, this creates really a difficult time, not just for my residents in ophthalmology, not just for the residents in ophthalmology, but in other areas. So they're struggle, they have some struggle on that part. So we have to show them what a wonderful value learning opportunities, and they need to learn to value the unexpected, because life is that way. Life is not planned. Life, you cannot predict everything on that. You cannot control, and the disease is the same. So we have to retake the value of unexpected, and have to and develop the skills to deal with that. So, and the other one is, let me move to a more systemic, just to support what Melchor just mentioned. Ourselves as a universities and academic health centers have to organize ourselves. We were like the beacons in all this lack of leadership, of good political leadership, because it's the same in the States, it's the same here in Mexico, it's the same in Brazil, it's the same in other places. And the academic health centers have this responsibility. We have to answer this social contract that we have with the society, and to respond effectively to them. And I feel it's a big change. It's a big challenge. Coming back, we are not doing that. Still, our coming back to normality is not well managed yet. So we still need to learn and show good examples how to deal with that.
Awesome, Dr. Valdez. You have a great experience over there in Monterrey. It's incredible opinions. Thank you so much. Anna, we have this next question, right? And the next challenge that we have, and say, what have you changed in your hospitals or universities to improve all these difficulties that we were talking about? Let's try the same order. Susan, what do you think?
Well, I think we've this discussion really just highlights how many of these challenges are universal. We also found the most difficult period to be early on in the pandemic, when our response was trying to be as conservative as possible, and substantially affected our resident training, access for patients to care. But during that time, we really had to hone our triage process to identify patients who were at the highest risk and truly needed to be seen at each of our clinical sites. We dramatically expanded our telehealth operations for those patients who could effectively and safely receive their care through virtual interactions. And of course, for ophthalmology, much of what we do is by nature a very in-person based exam. So our virtual options were limited, but we tried to push the envelope, sort of push boundaries as much as possible for things like neuro-ophthalmology, exams, etc. We also implemented changes like drive-through intraocular pressure clinics or exam tests where patients could come in their cars, have a pressure check without getting out of the car, and minimize their time and exposure within the clinics. We've implemented screening for all staff and all patients. Staff are required to complete a questionnaire every day before they enter the building and indicate whether they have had any potential exposure or symptoms. We have an aggressive policy where we work with occupational health for anyone who is considered at risk or potentially exposed so that they stay home and don't come into work until we know that they are safe to do so. We have also been screening all of our patients in advance of their visits where able, and when they enter the building, along with whoever is accompanying them, to see if they have had any exposure or symptoms, and then triaging them appropriately, either to be evaluated for potential COVID or to be evaluated safely in the eye clinic. We've had to make sure that we have personal protective equipment available for staff and that they're wearing them properly, and also making sure that our patients will wear masks and also being safe within the clinic space. We've tried to maximize our residents and trainees' time for high yield clinical care. So if some clinics or operating rooms have been less busy, or some providers, their schedules are no longer as robust as they had been previously, or the educational experience is different, we've shifted residents into other opportunities. And we've made sure to check in with them regularly regarding their symptoms too. If they have any, they need to report them to us. And they're also having access to adequate PPE, having a policy around seeing hospital consultations. It's been a substantial change in our workflow. I think we've tried to adapt to what is, I guess, the new normal, the word that people have been using at length during this pandemic, but it's definitely been a challenge.
Thanks, Susan. I like that the IOP in the car, to check the IOP in the car is very interesting, right? We were talking before we started about all the pathologies that are getting worse because people don't go to the ophthalmology clinic to avoid this.
Absolutely. We've heard a lot of anecdotal stories within ophthalmology and frankly, even outside of it, of a lot of, whether in part due to delay through the pandemic or what reason, patients coming in with very severe disease.
Absolutely. Well, Gabriela, your turn.
Okay. We implemented several actions to face these challenges I mentioned before. We increased the interactivity in our morning lectures. We have been broadcasting our lectures for the last, I would say, 8 to 10 years, but residents were used to be at the hospital with the faculty or the lecturer while the lecturer was giving the lecture. But the truth is that it's not easy to keep your attention on an online lecture the same way as when you are face to face. So we encourage our faculty to provide or to include questions and answers via Zoom or by chat, clinical cases, more conversational sessions like journal clubs, etc. Then we moved our assessments online via Zoom. Instead of using our traditional multiple choice question exams, we used more group discussions of clinical cases and even concept maps for assessing our residents. We found it was really challenging to monitor and keep reliability of multiple choice questions exams. So I think that one of the challenges that we'll have for the future is to try to move to different ways of assessing residents' knowledge. We were able to complete the Boston-wide virtual surgical curriculum thanks to the Massachusetts Eye and Ear Ophthalmology residency. We use this curriculum that is full of videos and cases. It's a wonderful, and I highly recommend it. Our expert cataract surgeons, we asked them to meet in the morning with the residents, so they were able to discuss these cases and these videos with the residents. Residents use their time at home to advance their research projects. So many of them were able to finalize their manuscripts or move on their protocols. And they were also participating in our regional congresses. We had many this year in our country. The training period and entry of new residents was moved from June to October. So we are just now receiving and welcoming our first year residents. And the national resident selection exam was moved also to an online exam, and the selection interviews were conducted via Zoom.
That's great, Gabriela.
I have a question
Please.
for Gabriela,
Yeah.
actually.
Sure.
So is your
Of course.
timeline shifted for the new residents who are starting in October? Will they then, you'll have a period where you have extra residents then, assuming the timeline goes back to a June start. Is that right?
Well, all the program, instead of finalizing May the 31st, it has moved the end to September the 30th from now on. So residents are, so residents are starting now October the 1st, and this will keep on for the next, I don't know how many years, but yeah. Yes.
Chris, okay, tell us about what's happening in Bascom Palmer.
Sure. I think that a lot of the things that have happened here are very similar to what's been happening with both Susanna and Gabriela, but every patient and every physician that walks into the Bascom Palmer Eye Institute gets screened with a temperature check and with a questionnaire to ensure that they haven't been exposed to COVID over the past 14 days or have any symptoms. Of course, patients don't necessarily tell the truth, especially if they're desperate. So, you know, you can't necessarily rely on that, but it's the best that we have. We have testing prior to any surgery. So patients will get a swab, a nasal swab for COVID testing prior to any surgical procedure. We've increased the time slots for each patient encounter. So that allows us to have fewer patients in the Institute at any given time. And in addition, we've also arranged for spaced out seating in our waiting room so that their patients can be at least 6 feet apart when sitting and waiting to see a provider. We've also adapted the concept of hybrid clinics where patients can come in on a day separate from the physician clinic, scheduled clinic visit. They can get their testing done, whether it's an OCT or a visual field, along with vision pressure, et cetera, and then come back and have either a phone call visit to review everything with regards to the findings of the exams, et cetera, or they can come in person as well for a short abbreviated visit. We did pilot the drive-through IOP checks like Suzanne did at Stanford as well. And we've tried to be sure to clean the rooms between every patient to sterilize it and ensure that no residual viral particles are there between patients. We've also put slit lamps, shields on all the slit lamps so that there's a little bit of a barrier between the face of the patient and the face of the physician. And all patients that enter are wearing masks. We give them masks at the front door, and we're all wearing masks when we see the patients as well. And as far as our education mission goes, very similar to Gabriela, prior to this pandemic, we actually had our residents come in every morning at 7 a.m. for their resident lecture, which was given by various faculty members. During COVID, we transitioned to a Zoom platform and we broadcast our lectures, not just to our residents, but we opened it to our entire ophthalmic community, both local and national, just in case others didn't have access to that type of educational content. And it was really a very powerful platform for us to expand our reach. And we would often see 100 to 200 people logged into our resident morning lectures, which was really fantastic. I think the residents felt a little bit disenfranchised as a result of that, because you can imagine that if your lecturer knows that they're lecturing to 200 people, they may not be quite as personalized in delivering the lecture to the residents. So we have adapted this model to have the residents come in live to an auditorium where the faculty member presents the lecture, but we also stream it on Zoom. And then we leave the last 5 to 10 minutes off Zoom so that the faculty members can interact with our residents one-on-one for any questions that the residents may have or that they may feel too embarrassed to share in a public forum, etc. So that has worked out fantastic. We've done the same for our grand rounds, which we stream in webinar format every Thursday morning, and that's been working well. And we're trying to continue our tradition of really exemplary education to our medical students and hopefully very soon to our international audience. So we're piloting right now a 2-week virtual ophthalmology rotation where our medical students who are visiting from other schools, they cannot be present live in our institution. They actually have to stay at home, but we try to make it as real as possible so they can attend all our journal clubs, all our morning lectures, but we've also opened up all our operating rooms so they can actually virtually scrub in with faculty, and the faculty have a microphone that they can explain all the steps of the surgeries that they're doing, and everything from the microscope is being transmitted. We've done the same for select clinics where we have found adapters that we put on our teaching scopes, and then we attach a cell phone, and then we're able to stream on Zoom the slit lamp exam and the 90 exam for our medical students to see live what's going on with these patients in the clinics, and they're able to hear the history as well and the interaction and the professionalism between the doctors and the patients. We've done the same thing in our emergency room, so our virtual rotators can actually see all the pathology and the volume and the fast pace in the emergency room through the slit lamp. We've done the same thing in our pathology lab. I got a special adapter for our pathology services so that they can stream to the students the microscope findings of pathology, which is a really important critical component of training. So we've worked really hard to try to enhance the educational opportunities, and hopefully if this pilot works out well, then we can expand it to our international audience and kind of resume education in the full kind of breadth that we had been trying to do earlier before the pandemic.
And Chris, I really want to recommend your Grand Rounds live because they're amazing. Thank you so much for that work, because it's incredible how we can have access to your academic Grand Rounds. It's pretty amazing.
Oh, thanks. I'm glad you log in.
Absolutely, absolutely. Well, next speaker, Melchor. Again, your turn.
Yes, I should have mentioned before that our university, the National Autonomous University of Mexico, has more than 12,000 residents from, all specialties and subspecialties in more than 100 clinical sites. So that makes a huge challenge in terms of the diversity of the clinical sites. Some are very high-end, rich, with all the technology hospitals, and some hospitals have very poor public hospitals that do not have a lot of resources, even the basic technology. So there was a lot of variation, so the challenge was multiple. I should say that one of the things that happened was the university did its best to meet with the coordinators of teachings of the clinical sites to try to decide what to do. Because at the beginning, in all these chaos that started in Mexico City, there was all these ethical questions about what should we do with trainees. For example, medical students were pulled out of the hospitals because they were just, I know it sounds not nice, but many times the students just get in the way of getting things done, and they consume all this protective equipment that is required for the nurses and the people that are all day in the hospital. So, but with the residents, it's a very different issue, because residents in Mexico are like the main working force in the hospitals. if you get the residents out of the hospitals, the whole system collapses. So there was a lot of support for the residents. It varied a little bit among hospitals, but the university did this huge effort in all the public media to get donations for, so many millions of pesos were used to buy protective equipment for the residents, and they were distributed in all the sites. That was a very nice thing. In that sense, Latinos are very cooperative when it comes to work with as a unit in the country. And the other change that happened was the sudden migration to the online environment. So some hospitals already had virtual learning environment well in place. So many others had to improvise a little bit. But fortunately, all residents have digital devices, and the internet access is more or less of moderate quality, but at least it's there. So almost everybody can get in line to share things and etc. So there was this cascade of webinars, journal clubs, etc. Everything was moved online, lectures. In these last few months, we have been trying to move from the synchronous activities like this one, where you have to be at the same time in several places, to try to promote more asynchronous activities, because at least in Mexico, everybody's at home. I mean, the residents are in the hospital, etc., but the families and all the other, a huge part of society is in lockdown at home. So it's very complicated to have all this space with an appropriate light and sound, etc., to have a good face-to-face experience in a synchronous manner. And we developed a couple of MOOCs. I put the links in the chat. A massive open online course we did with Jorge's team in the Tec de Monterrey for assessment in clinical scenarios. Because in the last few months, after March, all Coursera and EDX, these massive open online courses were like this, more than 700% increase in use. So we just finished a massive open online course on the role of residents as teachers. That will be presented next week on 1 week from today in Spanish, because there's very little material in Spanish for residents all over the country. So one of the things that we're trying to do is to promote the sharing of resources among all the clinical sites. And one of the things that we're also trying to do is to focus. I mean, if you cannot operate because all the surgeries, scheduled surgeries are canceled, you have to develop all the other things that a surgeon needs. I mean, many of my best friends are surgeons, and I am convinced that the psychomotor skills are critically important, but all the other skills like team-based learning, crisis management, leadership, communication, professionalism, etc., are critical. And you can use this time where you do not have a lot of surgeries to develop all these manner of competencies. There was also a lot of mental health support for the residents, and I mean, we're working on that. And regarding the assessment, it has been very complicated, as you said, the online exams, to have them have a complete validity and reliability is difficult. And I mean, we try to focus more on this assessment for learning during the process. And we piloted a tele-OSCE, this objective structured clinical examination, with the technology, because I mean, there is no way to have face-to-face assessment today. And there's some silver lining to this also, because now residents have more time to study and to do other kinds of things. I leave it at that. Thank you very much.
As you said, Melchor, we had the time in the lockdown to learn or to explore another fields, right? We have time to study so many things that before we couldn't do.
Yes, you can study for the boards too. Yes.
Well, Jorge, your opinion about this topic?
I think we approach the same way that many of my colleagues already mentioned. We have a lot of courses moving to to Zoom when we were using that platform. Actually, the entire university move all the courses, undergraduate, graduate courses. But in the clinical, I think clinical scenarios were the most challenging ones. We have, as somebody mentioned, virtual rounds, and also in the office, we create that. All the journal clubs, case discussions. We have to enrich the activity. Also, we have, I think the clinical case discussion became one of the most used ways to try to compensate the lack of clinical activities in the discipline area, or in this case in ophthalmology. Also, we have to use the simulation center first to train them to use the personal protection equipment. So we have to love that. But what we did in parallel was to train the faculty. I think one of our first actions was to train the faculty to use all these tools that we have already in place. And I think that's one of the good things about the pandemic, force everybody to move in that direction. We already have a lot of things already there. The learning platforms, Zoom, Skype, a lot of the other ways to communicate, even the things that design for instructional design, for pedagogical design, they were always asking us, try to do this, try to do this. Well, now we have that opportunity. We train all the faculty in the medical school to move in that direction. And actually, something very interesting happens. They start to share the good practices. So we actually institutionalize one day in the afternoon. Actually, it's on Wednesday afternoon, in which they share what they are doing, all the innovation they are doing in the clinical settings for different areas. One of those were ophthalmology. But it's very easy to translate from one, let's say, surgery to ophthalmology and then to internal medicine. You just need to adapt those things. So with that, we create like a movement within the faculty, in which the one call the other one, and that call the other one, and those sessions start to grow. So at the end, we have a lot of people learning from others and trying to apply that to their own group or to their own activity, if they were in the clinical settings, if they are clinical teachers. And I think right now, according to the experience that we already have, it's going to be very difficult to go back in certain activities. For example, case discussion are so rich in this environment, and with, as somebody mentioned, we start to have international guests to discuss with us the cases. That's very easy right now. So a lot of friends that you already know here in the Untitled University, I invite them to discuss the case with the residents. Jose Alvaro from Brazil, Guillermo Mesco over there from Bascom Palmer, a lot of people from around the world, our friends. Really, we create a kind of community, and they invite us also to discuss in other places. So this is one of the good results of this challenge that we face, and I think it's going to be here with us. It's going to stay. This type of changes. Some others, well, we are now we are getting to going back to the clinic, the way we need to do it, how we do it. We are having our second wave here in Mexico, in Monterrey, so very much like in other places, in other cities like in the States or Europe. So we are facing how to deal with that, trying not to lose what we already are getting in clinical practice.
Thanks, Jorge. Excellent, as always. Well, we have the last question, and maybe the most interesting topic. It's how do you see the future, maybe in the next 3 years, on the medical education and residency programs, especially in ophthalmology and other surgical residents?
I already answered that in the chat. I just put a paper over there, so I can leave. I'm joking.
Oh, please, just wait a few more minutes, doctor. You're
I'm
finishing.
joking. I'm enjoying a lot.
Okay, Susan.
That's an excellent question. I think some of it remains to be seen. There have been a lot of new adaptations that we've mentioned, others have mentioned, and increasingly a shift to a different approach to patient care, really much more careful about our infectious prophylaxis practices. And then also this shift toward virtual education. I think it's gotten many of us to feel much more comfortable with doing conferences, doing lectures via Zoom, but there's also, or other virtual modalities, but there's also a lot of just missing the in-person interaction too in these settings. So it remains to be seen, but I suspect we'll come to a little bit of a hybrid with certainly returning to some in-person small group discussions, for example, but retaining the option and the flexibility, especially for locations that do have many distal sites. Like I'd be interested to know of the 100 clinical sites in Hunan, for example, if they are geographically spread out as well. But there's an opportunity to really continue these shared educational resources as programs open up their didactics, their grand rounds, their lectures to other institutions. We'd also piloted, especially early on in the COVID period, having more shared educational activities with other institutions within our geographic region, and doing most of those remotely via Zoom and other formats. It's started the process of being able to connect with each other, and I think we'll likely continue that even after COVID on things like mock oral board sessions, etc. Also, for surgical training, we've really had to push the envelope at many sites for using simulation and really having more of a structured surgical curriculum, teaching people in a very stepwise manner, utilizing wet lab more to maximize the value of learning in patients and doing care in person. So I suspect that those things as an overall positive change, irrespective of COVID, will likely continue. It'll be interesting to see how people return to things like shaking hands and not wearing masks after COVID, or just being much more careful and cleaning the exam rooms. I have a feeling some of these patterns will be ingrained even when we go back to normal.
Thank you, Susan. Thank you. Gabriela, your turn.
Okay, I think that there are several changes that we could make to our training programs independent of the pandemic. As Melchor and Jorge already mentioned, there in Latin America programs, there are many changes that we could implement. I will make some suggestions, and these are based on a survey that we conducted last year for the Pan American Congress of 140 residency programs in the region from 15 countries in Latin America. And many would not require big investments, but the will of the leadership of the programs. For example, we need to improve the quality of our didactic lectures by adding more interactivity. As I said before, it's not the same thing to give a lecture online than to give it face-to-face. So this is something that we need to improve. We could move to more interactive sessions or formats like the flipped classroom, where residents in many programs in our region, it's residents that give lectures to other residents. It's not the experts, but it's actually the residents that give lectures to other residents. So instead of having residents passively receive this content, we could have them watch the wonderful, high quality pre-recorded lectures that they're already in the internet and that have increased so much thanks to the pandemic. They could watch them at home, and then they could come to the class to discuss cases or to make questions to the experts. we should improve the way we assess our residents. Instead of assessing only medical knowledge, and this is the most common kind of assessment in the region, we need to move to other kinds of assessments, assessing other aspects of medical competence, like Melchor said before, professionalism, communication skills, critical thinking, and other aspects of medical competence. And we need to assess residents in the workplace, in the clinic, and in the operating room. We need to improve the way we teach our residents how to do surgery. Our numbers in the majority of the programs are in general very low. We need, as Susan said before, make more use of simulation. We need to extra use every case we have. So we need to be more prepared when we when our residents get to surgery. We need to increase our publications also. Our numbers of publications are in the region in general very low, with the exception of Brazil and Mexico that are a little better. In the rest of the countries in Latin America, our number of publications are very low. So we need to train not only the residents on how to do research, but also the faculty. And as Jorge also said, it's necessary to improve and increase the faculty development initiatives. It's necessary to train our trainers and also to have our programs participate in processes of accreditation. And in summary of all of these, we need to make medical education a more attractive, rewarding, and well-paid subspecialty. So more and more ophthalmologists would like to choose this subspecialty of medical education as a career path.
Thank you, Gabriela. Thank you so much for your words. Chris, what do you think about it?
Yeah, Andres, I don't know that I could put it any better than those two.
Yeah.
I'd be basically repeating them. I just love this opportunity to be able to cross-cultivate ideas between different institutions, both locally, regionally, nationally, and internationally. And that, I think, is a huge success from us being able to be comfortable with this platform of using Zoom and similar modalities. I think that a big emphasis now has been placed on simulation, largely because we have had a situation where we were not allowed, our residents, many residents in the United States were unable to operate. Mm-hmm. And so the importance of simulation rises. However, the technology of simulation is not quite where it needs to be to serve as a perfect tool to assess someone's competence in the operating room. And I envision that as these different individual groups come together to create better simulation programming, that there will be a standard by which our trainees can actually be carefully and adequately assessed with regards to surgical skills. I think that that's very, very important. You don't want a dangerous surgeon out there. Right now in the United States, it's basically on the onus of the residency director to sign off on the competence of the resident, regardless of the number of cases that they've had. And I think that's a huge responsibility on one person. And I think that there may be potential conflicts within that one person as it relates to either letting that resident move on versus putting someone out there who's a risk and a menace to society's and vision. So a little bit more of a standardized way to assess surgical competence is going to be important. And I think we're getting very close to that, but I think we also need to study it very carefully before really implementing it.
Great. Melchor, Jorge, because I think we are all agree about this, but what about you guys? What do you think?
Okay, so that's funny because in 3 years we will still have the same government that we have today. So I'm not very optimistic about it. But I mean, you can dream.
Let's think about 5 or 10 years. No worries.
I haven't decided what to do this weekend, let alone 3 years. I certainly hope that we professionalize more the educational process. I did a master's in medical education in 2003 in the University of Illinois at Chicago. It's been almost 20 years. And in this period of time, the number of masters in education program for the health professions has increased incredibly. There are more than 200 medical education or health professions education master's programs on the world, and many of them are online. So there is this movement to have people in the educational positions in the hospitals and the medical schools that are physicians, clinicians like myself, a pediatrician. I worked in pediatric intensive care for 20 years, that actually have training in education, so we can have this dialogue, these difficult conversations that we need to have to strike some balance with all the enormous amount of work that residents have to do, but also to worry about them as human beings, because I mean, I did the residency in pediatrics in '85, and the harassment, the sexual harassment has not gone away. I mean, this year we had in Mexico a lot of public manifestation regarding the maltreatment of women in all places of society. So I hope that in 3 years we have really moved in that direction to have these more human residencies in our country, and that we worry more about the curriculum not just as a document that's static in some drawer in the medical school, but the curriculum that focuses more on competencies. I know many medical schools have this competency-based education model and the entrustable professional activities paradigm for assessment, etc. So we need that, because otherwise we continue living in this time-based medical education training that you are supposed to be a good surgeon in 3 years. We've been doing in the last decades all just increasing the amount of time that people spend in the hospitals. And I know it is very difficult to document the outcomes of the different programs in time. I put a link in the chat about this nostalgitis imperfecta profunda, where you think that everything was great before it was not so great. I mean, this event that we're living now, it's we hope it's a once in a lifetime event, and in the next years we will have some kind of balance where people that require a lot of psychomotor skills training can actually be in person in several places. So I also hope that we develop more extended reality. I mean, there's a lot of videos and multimedia, etc., but there is a huge field for development with the use of haptics, these things where you just not see, but also feel through the technological interfaces. So I think that's very important. And the other thing that will happen is that we will have these hybrid models of education. I mean, there's just no way that we tear down hospitals and office buildings and universities and build them again with the new requirements for architecture for the social distance. I mean, there's just no way. There is no conference room that can have more than 3 or 4 people keeping the social distance requirements. So I think that the hybrid model is here to stay. And I hope that this disdain, like thinking about online education as a second-class citizen in higher education, will really go away. And now we really forget about this artificial dichotomy between face-to-face and online, because, I mean, we have to recognize that all of us, I mean, just remember before the pandemic, you went to a restaurant on the weekend and all the families around you, everybody was with the cell phone and those, I mean, so they were face-to-face, but they were communicating with the devices. So we have to incorporate those in a more healthy manner. And I think that, I mean, I'm optimistic that this will change for the better. And well, that's about it. I hope that we have more interprofessional education, that we conceptualize the learning environment, not just the formal, I mean the hospital, the medical office, or the operating room, but this learning landscape where learning happens in a lot of ways, in the informal cafeterias, ASOLs, parks, etc. So we will really go along with that. And I hope that faculty development really improves, because most clinicians hate having faculty development activities, but we need them. Otherwise, we will not use the technology in a educationally appropriate manner. And we will, as sometimes happens, just move the lecture from face-to-face to Zoom. We have to improve our pedagogical abilities. So that's about it.
Absolutely. Jorge?
I will try not to repeat what my colleagues already says, and I agree in everything. But let me point out, first, I really like what Chris says about how we use Zoom and move internationally, share a lot of ideas, way of thinking, see the situation or other parts. And that remembers us that we are in the same human enterprise, improve the well-being of others. It's the same. It's in the States, it's the same in Argentina. So in this pandemia really make us to reflect on how absurd are some divisions and the borders and all that. And because we can create a global community, regional communities, broader, that sharing this good will that we have. Let me move lower level, more practical one. I really like what Gabby mentioned and Melchor mentioned. We have to professionalize the faculty. Don't assume that because I am a very good clinician, I'm a very good surgeon, very skillful, I'm a good teacher. You have to learn to be a teacher, and we have to professionalize that pathway. It's in the same way that being a good student, being a good resident doesn't make you a good ophthalmologist. You have to learn over the way to develop other skills. And I think besides of moving technologically, we got a lot of advances on the technical part, Zoom, simulators, virtual, all that, and the clinical skills. We need to move for a competency-based education. Right? Melchor mentioned that, and not just when we have a problem still. We always mention competency in ophthalmology field. Everybody always relate to surgical and simulators. Let's do more surgeries. No, actually, I propose to move away from the minimums, the number of surgeries that we have to do. Now, people can do 50 surgeries and it's still not skillful. We need to develop competencies, teach systematically, evaluate systematically, not in the way we are doing that part. And also we have to take, for example, the entrustable professional activities from already well developed in medical education to residency, postgraduate education. What are the entrustable professional activities that we need to develop in residence? Not the minimum of surgeries, the minimum number of surgeries. If we still keep in that, we will not advance. We need to develop in the residency training, in ophthalmology residency training, the milestones. And like a gatekeeper, when we stop a resident and we don't allow them to move ahead, I don't care if he's a good surgeon in cataract. If he's a bad person, I will not allow them to move from the first year to second. Actually, I will question seriously his presence in the residency program. I don't care if he's a wonderful guide to answer the knowledge test. If I have a lot of complaints of his unprofessional behavior with the colleagues, with the other genders, he discriminates and all that. I don't want that to be people from that come out from my institution. And I'm saying this as a dean, not just as a associated teacher. So we need to develop that kind of milestone. Obviously, a better ways to assess. Gabby mentioned that. I think we need to really underline that part, because we need to redefine our outcome, our profile of the resident. It's not a guy who has is a very successful career, having a lot of surgeries, a lot of cataracts, a lot of excimer laser, and all those promoted by the pharmaceutical industry. No, we need people who treat people, and this wonderful guy who treat wonderful persons. That's the type of person that we need to produce in our settings. Big challenge besides the competence-based education, bullying within the residency. We still have to deal with that. I have no problems as a team dealing with that than with people that of lacking of knowledge. I have unprofessional behavior in the faculty and unprofessional behavior in the residents. We need to really banish this bullying culture, this hierarchical approach that we have in medicine. We have to be we create safer environments that promote inclusion of all different ways of thinking, different races, different whatever. We need to reach a point in which we don't need to care about that because it's so inclusive, it's so safe that it's no longer a really a challenge. So we still face a lot of challenge in front, not just the COVID or the pandemic. We need to change the way we are improve, the way we are educating our next generation of ophthalmologists.
Wow, thank you so much, Jorge. Such a beautiful words. Valeria, we are finishing. We wanted before finish show the Ophthalmic University point of view about the last topic, how we see the future. Valeria, do you want to say something before we finish? Any comments?
No, I think it's important for us to look ahead and try to imagine our near future for the future doctors and the residents, and how can we guarantee that the quality of the education is going to be there for them, because they are the ones that are going to do surgery on us probably. So we have to get to be worried if these doctors are the ones that are going to do, you know, our cataract surgery in 30 years or 20 years from now on. And how can we guarantee all the patients to be safe in their hands? Because we know the clinical and the theory is guaranteed through Ophthalmic University and all the webinars and all the things that you already said, but how can we guarantee the hand practice and how they will do the surgery in the future? Because this is not going to end at least in 2 or 3 more years. I don't know, maybe the vaccine will come next year as some say, but you never know.
Well,
thank you for joining us.
I think that we have today 2 important words, simulation and hybrid, that concept. So let me share with you this concept that is the point of view of Ophthalmic University. As you know, we are obsessed with education. So we developed this program, the hybrid blended education program, and has 3 main stages: the online teaching, because as Melchor said, the online classes, the webinars are here and they will stay. So the first stage is the online teaching, then you will be able to have the hands-on individual training, right? The simulation surgery. And at the final, the counseling and community stage. That's the last stage, because we don't want to lose the contact with the students. It's not just, okay, you just finished the simulation surgery, goodbye, and I don't know what's happened with you. We want to know the performance of those surgeons in their countries. We want to make a community. So let me show you this process, how we think about it. First of all, we have our campus, virtual campus, where you can get different courses, several courses in ophthalmology training. After you pass this stage, we just presented or launched the hybrid campus, this space, physical space where you can go and train all the abilities, the skills without patient. And let me show you this video from the presentation last 24 September. So these are students, real students practicing doing simulation surgery with big eyes or with artificial eyes. We want to share a space where you can go and do all those surgeries that you cannot do in patients, right? And there is no risk here. You can practice as many as you want, and that is the good part of the hybrid education. This is our classroom. You can see microscopy, television, state-of-the-art technology. We have a refractive surgery OR and different phaco machine. And so you can practice all the specialties here in the Ophthalmology University campus. And the end, we have maybe the most important stage is the community. I think Dr. Valdez talked about this, about to make a community between all the surgeons around the world. We keep sharing knowledge, we keep sharing practice experiences, and the travel is not finished when you finish your practice. So this is how Ophthalmology University see the future. We need to redesign the ophthalmology education, adapting to the new times, adopting new technology, and we need to democratize the ophthalmology education so that more ophthalmologists have the possibility of being trained safely and at the highest level possible. I think that is our dream, our vision about this. Okay.
And that you can invite us to a next session on continuous professional development that Gabby mentioned and talk about lifelong learning strategies. This is an entirely other chapter.
Absolutely.
Besides resident training.
Absolutely. This is a complement, right? It's not a residence program. Of course, this is not just for fellows or residents. Maybe you're a surgeon and you want to improve some technique or something, and you cannot practice, as just said, with patients sometimes.
For example, in the States, they already have already in place the maintenance of competence concept that we still struggling to develop that in Latin Americas, for example. And that concept of maintenance of competence, being competent over your professional life is very important, and we need to develop better strategies for lifelong learning.
Totally agree, doctor. Absolutely. Well, final words, guys. We are finishing. Okay, Ana, Valeria, Susan, Gabriela, whatever you want to say. Thank you so much for being here.
I'm sorry, Andres. I want to thank everyone because this is really useful for every one of us, because I think we're facing all the same problems. We're all facing the surgical problems, the clinical, like less patients in the clinic, so not that much exposure. We're having problems with the exams and how do we know if our residents are learning or not. So all the things that you said in the webinar were really useful for all of us, so we can change, we can stay like doing this kind of webinars, so we can complement each other and have ideas exchange. So I think this is really good, and I want to thank everyone for being here.
Definitely. We will definitely try and make some of your of the things you said in the webinar, like the I don't know if the drive-through IOP, but definitely the teaching with the cameras and the OR adapted so they can see maybe at home. I think that's something that we definitely are going to try, and maybe, I don't know, meet again in a couple of months and see what has happened and what the University of Mexico, that's our mater, well, from us, not for Jorge, but can help us. So thank you all for joining us.
You are always
you.
welcome if you want to change university.
You already did.
Okay, thank you so much, Gabriela, Susan, Chris, Melchor, Jorge. Thank you. Thank you, Jorge, doing the translation. We talk a lot, so for sure, Jorge, it's pretty tired. Thank you, Jorge, from Guatemala. And of course, all the attendance. Was an incredible webinar. Will be, there is Jorge. Thanks, Jorge. Thank you so much.
Thank you.
Will be
Gracias.
online in YouTube, so you can enjoy it later. Thank you so much.
Thank you for
all.